Awesome.
Well, good afternoon, everybody, and welcome yet again to another Samaritans First International Health Forum on this beautiful spring day. Delighted to have you guys with us. If you remember, love for you, if you would, on the chat box to your right to sign in, just putting your name and where you're located. And don't forget, at the end of the presentation, we dedicate a number of minutes to Q&A at the end. So please do participate in that component of the presentation today. Before we get started, as always, we're going to open up in a word of prayer. So please bow your heads with me. Dearest Heavenly Father, thank you for this beautiful day. We thank you, Lord, for this technology and the opportunity, Lord, just to have this presentation. Lord, just to learn from one another so that we may serve well in medicine to present the gospel around the world. And we ask this in Jesus' name. Amen. All right. Well, delighted today to introduce a good friend of mine, Dr. Jordan Rupp. Dr. Rupp did his medical residency training in emergency medicine at Indiana University and completed fellowships both in global health and emergency ultrasound at Vanderbilt University. He is currently practicing in the emergency room there at Vanderbilt University Medical Center. If you'll recall, several presentations ago, we had Dr. Mark Peel present ultrasound dedicated to pulmonary evaluation. And so you can look at today as sort of a sequel to that. Today, Dr. Rupp will be presenting about EFAST pathology. So we're delighted for Dr. Rupp to present. So we'll turn it over to you, Dr. Rupp. Thank you for being with us.
Yeah, thanks so much for having me. Excited to talk about one of my passions, ultrasound, and the EFAST exam is the initial point-of-care ultrasound application. We use it a lot in emergency medicine. It has a lot of applications in the global health setting, in missions, whether it's trauma, can help in OB care and going forward. So we'll jump right in. I've got a lot of slides, and we'll move right through. We'll get started with the case. And we can go to the next slide. So the first case will just be a case of a 7-year-old girl that maybe Lance and I took care of together while we were at the EFH in Iraq. She was struck by mortar fire. She's got a laceration to her leg. She's got scattered abrasions. And if you can go to the next slide, she's tachycardic, heart rate in the 130s, and her blood pressure's really soft. So next slide. So is she hypotensive from the vascular injury? Is she hypotensive from a C-spine injury with neurogenic shock? Or is she hypotensive from a bleed elsewhere? So we're going to learn how to use the FAST exam to further evaluate this patient. I'll give you another example. 31-year-old male. This gentleman was struck by shrapnel from a grenade dropped by a drone in Mosul. His blood pressure is a little lower, 60 systolic, and his heart rate's 145. He's got multiple penetrating wounds, and we need to figure out why he's so hypotensive and tachycardic. So could it be from one of those small lacerations bleeding? Could it be an intra-abdominal injury, or could the injury be someplace else? Next slide. So what I'm teaching today is point-of-care ultrasound. So we're not talking about doing a completely comprehensive ultrasound of everything in the abdomen. When I'm talking about point-of-care ultrasound, I'm talking about a very focused ultrasound exam where I approach the patient with a very specific clinical question. So the way I compare this is, a comprehensive ultrasound would be like opening it up in a newspaper and just seeing what all kind of news happened throughout the world yesterday, as opposed to point of care ultrasound. I'm going to go to Google and ask a very specific question. Did the Cubs win last night? So with the EFAST exam, there's going to be 4 main clinical questions that we're going to try to answer. Is there free fluid in the abdomen? Is there a pericardial effusion or pericardial fluid surrounding the heart? Is there free fluid in the chest? And is there a pneumothorax? These are going to be major causes of morbidity and mortality and trauma. And like I said, this can be used in some other situations as well. Let's say looking for free fluid in the abdomen in someone you're worried in ectopic pregnancy, let's say. Next slide. So what are we looking for? You can click through. So you can look for pericardial fluid in the chest, hemothorax, pneumothorax, or we can go down to the abdomen and look for free fluid in the abdomen. Next slide. Here's a couple important just general principles that we need to keep in mind as we're talking about the FAST exam. Next slide. So the more blood that a patient loses in their chest, around their heart, or in their belly, the more sensitive the FAST exam is to find it. So in the initial studies that Rosicki performed in Atlanta, when the FAST exam was becoming in vogue, every patient that was hypotensive, blood pressure less than 90, she was able to find where the bleeding was every single time. Next slide. There's no radiation, and there's very little cost to repeating an ultrasound exam. So if the patient is waiting for further testing, waiting for blood test to come back, you can repeat the ultrasound exam and increase the sensitivity by looking for a slow bleed that may take a few minutes or an hour to accumulate. Next slide. So ultrasound is 93% sensitive to detect a pneumothorax, and it's very sensitive for a hemothorax as well, which is much better than a chest x-ray. Next slide. And ultrasound is the gold standard for pericardial effusions. All right, let's get into it. So let's talk about the abdomen first. When there's an injury inside the peritoneal cavity, blood's going to collect in one of three places: the right upper quadrant, the left upper quadrant, or down in the pelvis. We'll start in the right upper quadrant. Next slide. So, when we're talking about blunt trauma, the spleen is the most commonly injured organ, but despite that, blood is most likely to move to the right upper quadrant, and that's where we're going to find it. Looking at several different studies, it seems like even early learners are able to find 250 milliliters of fluid reliably in the abdomen. Next slide. So here's where we're going to look. We're going to go to the right flank of the patient. We're typically going to use the curvilinear probe. Sometimes if the patient's either really obese or if they're really have really narrow openings between their ribs, we may use the cardiac or phased array probe. But we're going to go on the right flank, probe marker up towards the head, and can click through to the next animation. And we're going to look directly over the liver. So if you just kind of think about maybe where a boxer might kind of do a punch to the kidney, then that's where we're going to place our probe. So we're going to look in Morrison's pouch between the kidney and the liver. We're going to look at the tip of the liver, and we're going to look at the costophrenic angle. Next slide. So Morrison's pouch is that potential space between the kidney and the liver. Next slide. All right. And so as a patient is lying in C-spine precautions, lying flat on a gurney, blood's slowly going to make its way to Morrison's pouch. While it's in transit, we want to also move our probe inferior and anterior to look at the tip of the liver. So next slide. The tip of the liver is going to represent the right pericolic gutter, and this is going to be the most sensitive view when we're looking for blood in the abdomen. So it's really important that not only do you look in Morrison's pouch, fanning through that area between the kidney and the liver, but I'm going to slide inferior and anterior, so towards the toes, a little bit towards the midline, to make sure that there's not any fluid collected along the tip of the liver. Next. Next slide for me. So here's where we might miss a little bit of free fluid if our ultrasound is only imaging at Morrison's pouch. So just make sure that we see the tip of the liver. Next slide. I think we're just going to animate. We're sliding inferior and anterior just to make sure we fully evaluate the right upper quadrant. Next slide. Here's some examples side by side with the caricatures. I just need to take a quick moment to thank Rob Ferry. He's one of my colleagues. Let me borrow his great caricatures that you're going to see throughout the lecture here. So on the left, you see the cartoon, and then on the right, we see a wedge of free fluid in Morrison's pouch. So the kidney has similar architecture from what we all remember from reading Netter. The liver's at the left side of the ultrasound image, and then that dark black free fluid represents blood. So anytime fluid is where it's supposed to be in the abdominal cavity, it's going to be nice, round, soft edges. Think about the gallbladder, the bladder itself, cysts. They're going to have nice, round, clean edges. Whereas free fluid in the peritoneal cavity is going to come to sharp points. So we're looking for that pointy black fluid. Next slide. Another example. This time you can see the fluids closer to the tip of the liver, and it's more inferior. There's actually quite a bit of free fluid here. Again, pointy black free fluid. Next slide. Here's a great example. If you look at the bottom left of the screen, you see the kidney, and then we see the liver coming in from the left of the screen. If we had only evaluated Morrison's pouch, we would have missed all this free fluid out by the tip of the liver. And so we see that liver tip just floating in the blood out by the tip of the liver. Next slide. Just another example, making sure that we fan all the way through this space, not just getting a single still image, but fanning all the way through, and you can see more pointy black free fluid in Morrison's pouch. Next slide. Again, more free fluid. This time, a slight variation. There is some clotting in the blood, which isn't uncommon to see. So that free fluid is starting to clot a little bit, and we see that hyperechoic, which is kind of a brighter echo texture than just the black, straight black fluid. Next slide. So this one's a lot more subtle. You see highlighted in the middle of this image is a great view of the kidney, and we see that cyst on the edge of the kidney has nice round soft edges. But if you look very closely, and it's throughout the whole clip it's not present, but on the right side of the screen we see just a tiny bit of free fluid at the tip of the liver with kind of those pointy black sharp edges. So this is a pretty subtle finding, but a good comparison of fluid where it's supposed to be inside that cyst, and then fluid in the peritoneal cavity where it shouldn't be. Next slide. So now we're going to move to the left upper quadrant. So the right upper quadrant's easier to scan. The liver is a great window to ultrasound through, and it's much larger. When we move over to the left upper quadrant, the spleen's quite a bit smaller, so you're going to want, and it's more posterior. So I typically will put the probe inside my hand, kind of a reverse grip, and put my knuckles on the bed, and then bring my hand up against the patient, bring the ultrasound probe up against the patient, and the probe's going to be a little closer to the bed, a little closer to the head, so we're going to scan a little more posterior and a little more superior. The other thing that's a little bit different with the left upper quadrant is due to the phrenicocolic ligament. So blood's not going to collect between the spleen and the kidney. It's going to collect superior to the spleen along the dome of the spleen. Next slide. Next slide. Thanks. So like I said, a little closer to the bed, a little closer to the head, knuckles on the bed, bring the probe up against the patient. We're going to scan to look for the spleen, but rather than looking between the spleen and the kidney, I'm going to look for free fluid along the dome of the spleen, coming up along the spleen tip. Next slide. One more time. One more time for me. So we can see that blood collects superior to the spleen, between the spleen and the diaphragm, and then wraps around. But because of this phrenicocholic ligament, blood's not really going to get between the kidney and the spleen very often. And so if I'm only scanning between the kidney and the spleen, I'm going to miss that free fluid. So I'm going to focus my view along the, just above the spine, between the spleen and the diaphragm. And that's where the first little bits of blood in the left upper quadrant are going to collect. Next slide. So here's an example, and a little bit of a small image, but you can actually see the phrenicocholic ligament outlined here. So it's a great image. You can see right in the middle of the screen is our spleen. To the right is the kidney. We can see our spine traversing along the bottom portion of the image, and then the diaphragm is that bright white line that's separated from the spleen, and we see that big wedge of black fluid between the spleen and the diaphragm. So that'd be a positive FAST. Next slide. Here we've moved the probe. This is a different patient, but now we can see blood collecting out by the spleen tip. Again, we're not seeing any blood getting between the kidney and the spleen, but we see a large amount of fluid out by the spleen tip. Next slide. Here's a clip. Right in the middle of our screen is the spleen. The bright white line that is moving with respirations here is the diaphragm, and a little bit of rib shadowing, but as those ribs get out of the way, we can see there's quite a bit of fluid separating the spleen from the diaphragm, and a positive FAST exam. Next slide. Here's a still shot. Have a great view of the spleen here, and then just a little bit of free fluid between the spleen and the diaphragm at the bottom left portion of this image, and that represents a positive FAST exam. So I know when I was first learning this, I was scanning between the spleen and the kidney, and I may have missed a few. Next slide. I believe this is an image that I got while I was at the EFH. Again, left upper quadrant view. Kidney is right in the middle of the screen. It's a little obscured by rib shadows. The spleen's in the top left, and we just see that tiny bit of free fluid starting to collect between the spleen and the diaphragm just over top the spine. That's about midway up on the left side of the screen. Next slide. So next we'll move down into the pelvis. So we've done the right upper quadrant where we're looking in Morson's pouch and the tip of the liver, left upper quadrant above the diaphragm and the tip of the spleen. And now we're going to move down into the female pelvis. Next slide. So obviously the female pelvis has different organs than the male pelvis, and so we're going to need to look in some slightly different areas. And also if the female is of childbearing age, it may be normal to just have trace amounts of free fluid in the pelvis. Just a couple things to remember. Next slide. So now we're going to move down into the pelvis. We're going to have the probe right at the midline with probe marker up towards the head. I really find it pretty crucial to perform this portion of the exam in sagittal. I was taught initially both transverse and sagittal were interchangeable, but I find that the sagittal just gives me a much better clarification of the surrounding anatomy and much more clarification on my diagnosis. Next slide. So like I said, probe marker is going to be midline, just above the pubic symphysis, probe marker up towards the head. You can see in the little cartoon, the pubic symphysis is the white circle. We're going to scan through the bladder, and we're going to identify the vaginal stripe just below the bladder. contiguous with the cervix and the uterus. Next slide. One more time, this is just a zoomed in approach. So the yellow line represents where the peritoneum runs. So you can see that the cervix, which connects the vaginal stripe to the uterus, is the border between the retroperitoneum and the peritoneum. So it's really important that I scan this area carefully because the first amounts of free fluid are going to collect in the pelvis here. Next slide. And where we're going to focus our view is in what's called the pouch of Douglas, that potential space between the uterus and the rectum. And you can see where free fluid will start to collect. Next slide. Next slide. Okay. And we'll show, next slide, show an image of what we're looking for. So this is just a reminder that if you don't have the depth of your ultrasound image deep enough, you could overlook free fluid in the pouch of Douglas. So anytime we're scanning in the female pelvis as opposed to the male pelvis, you're going to need extra depth because we're looking deeper in the pelvis. Next slide. Okay, so make sure we extend our depth a little bit deeper. Next slide. Here's an example on the left side of the screen, and compare it to the cartoon on the right. So top middle of the image, we see big black anechoic structure, which is the bladder. And then if you go straight through the bladder, we see the vaginal stripe and the uterus. And then underneath the uterus, we see a black triangle of free fluid, making a positive FAST exam. Next slide. Here's a video clip. So at the top right of the screen on the image is the bladder, and then scanning through the bladder, we see the vaginal stripe, and then we see an anteverted, anteroflexed uterus, and then we see all that pointy black fluid to the left of the uterus. Again, starts in the pouch of Douglas, but now it's collecting further anterior. This is a large amount of free fluid in the pelvis. Next slide. Here's another example. Top right's the bladder. Scanning through, we see the vaginal stripe, uterus to the left of the bladder, and then adjacent to the cervix, we see a collection of free fluid. Now you can confirm in the transverse, and I usually do. The difficult thing about scanning only in transverse is if you're aiming deep in the pelvis and angling back, you may go through the bladder and scan into the retroperitoneum without actually scanning into the peritoneum and overlook free fluid. So I find that the sagittal view increases the sensitivity and the specificity of my exam because I have a much better understanding of the surrounding anatomy. Next slide. Next slide. Okay, we can move forward to the male pelvis. So slightly different now, we're going to be looking in the rectovesicular space, so that space between the bladder and the rectum. Any amount of free fluid is going to be abnormal, never normal in a male. Next slide. So same approach, sagittal orientation, probe marker up towards the head, just above the pubic symphysis. Next slide. Okay, so we're going to identify the bladder. This time, instead of identifying the female structures, we're going to identify the prostate and seminal vesicles. which in the cartoon are blue and green in the bottom right corner. And then we're going to look for free fluid collecting between the bladder and the rectum. Next slide. Great. One more time. So in yellow, we've outlined the peritoneal cavity. You can see that it traces along the rectum and then ends at the seminal vesicles, which are the green area, and then angles up along the bladder and then around the abdominal cavity. Next slide. There we have the prostate and seminal vesicles labeled for you. Next slide. You can see here's where free fluid in the male pelvis will gather. So if I'm only looking in the transverse orientation and I scan through the bladder and the seminal vesicles and prostate are in view, then I'm not going to see the peritoneal cavity. And it's very easy to overlook free fluid. I've taught a lot of residents and fellows and seen the FAST exam performed a lot of times, taught it a lot of times, and very common mistake for folks that are only using the transverse view to aim too far posterior and miss free fluid that could be in the peritoneal cavity. Next slide. One more time. So here's a good example on the right. Right in the middle of the ultrasound image, we see the bladder. Just underneath the bladder to the right, we see two dark structures. Kind of looks like a bird's head and a bird's beak. That's the prostate and seminal vesicles. And then bottom left to the bladder is free fluid in that rectovesicular space. Next slide. Here's a clip. This time, the prostate and seminal vesicles are just off the screen to the right. On the ultrasound image, there's a really large bladder. And you can see there's just a tiny collection of pointy black free fluid inferior to the bladder. Next slide. Here, this is the same patient. I've just adjusted my ultrasound probe a little bit. Now the prostate and seminal vesicles are more easily viewed on the right side of the screen underneath the bladder. Again, looks like a bird's head and a bird's beak. And then adjacent to the seminal vesicles, we see that dark, pointy black fluid. That's a positive FAST exam. Next slide. So like I said, you can still use the transverse view to evaluate for free fluid, and here's an example of a positive FAST in the transverse plane, scanning through the bladder first, and then it looks like this patient might have two bladders, which is always abnormal, and that's a positive FAST exam. Next slide. All right, so just to recap, when we're looking in the abdomen, there's three main places that fluid will collect. The right upper quadrant, we looked in Morrison's pouch, and then the tip of the liver. Left upper quadrant, we looked on the dome of the spleen and at the tip of the spleen, and then down in the pelvis in the pouch of Douglas in females, and then in that rectovesicular space in males. Now we're going to move up to the chest and look for hemothorax and pneumothorax. Good advance for me. And then we're also going to look subcostal for hemopericardium. Next slide. And then looking in the costophrenic angles for hemothorax. Next slide. Anterior chest, we're going to look for lung sliding, which is going to represent normal lung. And if there's a lack of lung sliding, then we'll look for pneumothorax. So let's do the subcostal view. And this is the fourth view of the traditional FAST exam. It can be extremely important in penetrating trauma. Hemopericardium is extremely rare in blunt trauma. It may occur more often, but most of the patients that have this issue from blunt injuries oftentimes, unfortunately, don't make it to the hospital. Next slide. So my approach for the subcostal view is I'm going to do an overhand grip on the probe, and then I'm going to go, as it's described, subcostal just underneath the xiphoid, and I'm going to slide just a tiny bit to the patient's right. And again, we're going to use the liver as a window to scan the heart. Next slide. So as the cartoon displays, we're going to actually be scanning through the liver first, and then we're going to scan the heart, and that's going to give us a view of the right ventricle, the right atrium, which will be closest to us, and then the left ventricle and left atrium will be further away. Next slide. All right, so here's what we're going to see. Next slide. We're going to be looking for a stripe of fluid around the heart. So the great thing about the subcostal view is when fluid is collecting in the pericardium, it's going to create this nice black stripe between the liver and the heart, which will make it really easy to see. Next slide. All right, so as that fluid collects, it'll create this nice black stripe between the liver and the heart. Next slide. And then obviously, as the pressure increases inside the pericardium, this is what tamponade will look like as we start to compress on the right side of the heart, which has thinner walls. Next slide. So here's a great example. So again, at the top of the ultrasound image, we're scanning through the liver, and then we see this thick black stripe all the way around the heart, and it creates this nice delineation between the liver and the heart that makes it easy to see. So on the top left of the cardiac silhouette, that would be the right ventricle, below it the right atrium, and then to the right side of the screen would be the left ventricle. Next slide. Always fun to ultrasound the heart just because it's moving and a little easier to identify that way. If you're having trouble getting a view, oftentimes if you're directly in that subcostal area, you could be kept going through the stomach, which might be filled with air. So just again, sliding to the patient's right a little bit may help. Again, we see that nice black stripe between the cardiac silhouette and the liver that helps us easily identify that there's a pericardial effusion. Next slide. Another example. So it is a little counterintuitive, but fluid will collect at the top of our screen first because we're scanning the heart essentially upside down. The most inferior portion of the heart will be at the top of our screen. So the earliest amounts of blood in the pericardium will be most easily seen between the liver and the right atrium, right ventricle. Next slide. Now we're going to take a look for blood in the chest. So we're going to move back to the costophrenic angles. I'm typically scanning these when I'm doing my initial FAST exam. So, let's say I'm doing my right upper quadrant view of Morrison's pouch and the tip of the liver. I'm just going to slide up a little bit further and look in the right chest for hemothorax. Main things we're going to look for, we're going to look just above the diaphragm, and we're going to be looking for what's called the spine sign. And we can reliably see about 25 milliliters of fluid in the chest, which isn't very much. Next slide. Next slide. So again, we're going to be, in this case, this is our left upper quadrant view. So I'm already looking on the dome of the spleen at the diaphragm. I'm going to make sure I'm aimed posterior so I can see the lumbar spine and the diaphragm. Next slide. Next slide. So typically, the lungs are air filled and sound does not travel very well through the lung. So when the sound waves hit the air, it scatters and doesn't come back to the ultrasound probe. But when there's blood in the chest, the sound will travel through that blood and we'll be able to see the thoracic spine, which we normally wouldn't be able to see because in an air-filled lung, the sound will scatter and we won't be able to see the spine. So we're going to clue in on that thoracic spine as a way of telling us, hey, there's some sort of fluid in the chest that's allowing me to see through to the spine. Next slide. So on the left side, we're usually not having to slide up very much. But on the right side, we're definitely going to come up a rib space. See if the next slide will pop up here for me. And as more blood collects, we'll be able to see it much more easily, and we'll be able to see more of the spine extending out from the diaphragm. So what I'm really cluing in on is at the bottom of the screen, the lumbar spine. When it comes to the edge of the diaphragm, if it stops, that's normal air-filled lung. Whereas if the spine extends past the diaphragm, then there's some sort of fluid in the chest, and in the setting of trauma, that's going to be blood. Next slide. Good. So here's our probe on the left upper quadrant. I'm scanning through a normal air-filled lung. Next slide. And so as I scan through the spleen and the diaphragm, and then through the lung, next slide, I'm not going to be able to see the spine past the diaphragm. So those are going to come to kind of a perfect L. Whereas if there's fluid in the chest, next slide, now I'll be able to see the spine past the diaphragm, and we call that a positive spine sign. And that's a indicator that there is fluid in the chest. Next slide. And once you do this a few times, it's takes a little bit of imagination at first, but once you do it a few times, it becomes really obvious and a very easily acquired skill. Next slide. Next slide. Should bring up image here. So I'm getting my typical, this is over in the right upper quadrant. So I'm just getting my typical Morrison's pouch view, and then I'm going to slide up one rib space to look for the spine sign. Next slide. And I'm just looking for that spine going past the diaphragm. It's really important that I'm aimed posterior, because if I'm not seeing the lumbar spine on the bottom right portion of my screen, I'm not going to see the thoracic spine. So I'm not going to get a positive spine sign ever if I'm not angling my probe posterior enough to see the lumbar spine. Next slide. And you can see in air-filled lung, we're just going to have shadow. So the spine's going to stop right at the diaphragm. As opposed to if there's blood, we'll be able to see past. Next slide. Here's a great example. So this looks like left upper quadrant view. You can see the kidney top right of the screen, spleen sitting right on top of it, the diaphragm's labeled, and then you can see the spine going past the diaphragm, and we see that big wedge of hemothorax in the lung. Next slide. Another example, this time looks like the liver. See the lumbar spine in the bottom right-hand portion of the image, and then see how the spine goes past the diaphragm, and there's fluid in that chest. Next slide. Here's a normal at the bottom of the screen and an abnormal at the top of the screen. So both are left upper quadrant views. In the bottom, we see the spleen with the diaphragm adjacent to it, and we see the lumbar spine come to a stop at the diaphragm, as opposed to the top of the screen where now we're seeing black wedge of fluid and we're able to see the superior to the diaphragm. Next slide. More examples. Again, large amount of fluid in the chest here. See the kidney and the spleen, and then a large amount of fluid in the chest, and we're able to see a positive spine sign. Next slide. Another example, you can see on the very left side of the image, we can actually see a portion of the lung kind of floating in that free fluid. But again, another positive spine sign. Next slide. Here's an example where we can actually see this patient's right lung kind of flapping in the breeze of the fluid in the chest. And we can see the lumbar spine continuing past the diaphragm, and we have a positive spine sign. Next slide. In this case, we have spleen, diaphragm, and you can see rather than being that dark black fluid, this was a patient that had a massive hemothorax and had a slightly delayed presentation to the emergency department, and that blood has actually started to coagulate a little bit. So even though it is not completely anechoic, meaning black, we can still see a positive spine sign, and we know there's some sort of pathology in that chest. So next we'll move to the anterior chest. I know I'm moving pretty quick to get through all of this, but I know you guys got this. So now we're going to move to the anterior chest, and what we're going to look for is a pneumothorax. So most of our trauma patients are going to come in supine, so most of the air is going to move. If there's any free air in the chest, it's going to move to the anterior chest, so that's where we're going to spend most of our time looking. And the way that we're going to tell if there's a pneumothorax is if there's an absence of lung sliding. And then we'll also talk briefly about the idea of lung point. Next slide. So we're going to go to the anterior chest. If I have my choice, I'll grab the linear probe. It's high frequency, allows me to see nearby structures, but if I already have the curvilinear probe in hand, I may just use that as well. Can you advance once for me? So what I'm going to look for is I'm going to set the probe right on top of the chest. I'm going to look for ribs. Next slide for me. I'm going to look for the shadow coming down from the ribs, and that's going to help me identify the pleural line. And all we're going to look at in this view is going to be the pleural line, and that's going to be the interface between the visceral pleura adhered to the lung and the parietal pleura adhered to the chest wall, and we're going to look for those two structures sliding past one another. In the case of a pneumothorax, there's going to be air in between those two structures, and so we're not going to see any lung sliding. So I'm always going to focus in, look for the rib shadow, which we can see here on the right side of the screen, and then just inferior to the rib shadow, we see that bright white line, and I'm going to look for any shimmering, glimmering. Sometimes it's described as ants marching on a log. And if I see that movement, I know that there's not a pneumothorax. I know that the lung is up against the chest wall at that level. Advance once for me. So I've just highlighted there the pleural line. Here's an example of a pneumothorax. So on the left side of the screen, we see a rib shadowing down. And then right through the middle of the screen, I see that bright white line. And then if I just focus all my attention, on that white line, I don't see any ants marching on a log, no shimmering, no glimmering. So we'll just highlight that pleural line for you again, no shimmering, no glimmering. So that's no lung sliding, which equals a pneumothorax. Same thing here. So bright white line right in the middle of the screen. I'm focused in. Do I see any shimmering or glimmering? No, so no lung sliding, pneumothorax. Two big mistakes I see my residents make here when they're first learning how to do this. Number one, they might get distracted and they might see movement in the intercostal muscles just above the pleural line. So if you've got a pneumothorax, you're short of breath, you're really going to be tugging to get a deep breath. You're going to start using those accessory muscles. But all we're focusing on is the pleural line. So don't let any movement more superficial to the pleural line confuse you with a pneumothorax. The other thing that might happen is if you get hit in the chest, you're probably not going to be taking real deep breaths. Let's say you just got a chest wall contusion, you might be splinting your breaths a little bit. So you may need to just ask the patient, hey, I know this hurts a little bit, but I need you to take a deep breath. And then you might be able to see the lung sliding a little bit better. Next slide. So the idea of lung point is that in any pneumothorax, there's going to be a portion, there's going to be a delineation where the lung is up against the chest in one area and not in another. And so if we can identify the border of where the lung is up against the chest wall and not up against the chest wall, this is 100% specific for a pneumothorax. So same thing, you're going to look for the rib shadows, look for the pleural line, and look for that shimmering and glimmering, and look for where those two come together. Next slide. And that'll be our lung point. So on this image, we see a rib shadowing down on the left side of the image. And then if you look coming from underneath the rib shadow, it looks almost like a little lizard's tongue of shimmering and glimmering, which represents where the lung is still up against the chest wall. But on the right side of the image, we see no shimmering or glimmering. And so we know that there's a pneumothorax, and we're actually right on the border of that pneumothorax, or what's called the lung point. Next slide. Another example, so we see lung sliding on the left side of the screen, no lung sliding on the right side of the screen. Next slide. All right. And then pulmonary contusion, I know you guys talked about B-lines before, but in the setting of trauma, if you see large collections of B-lines, that can represent a pulmonary contusion. Next slide. So these lines definitely need to come from the pleura and not from anywhere else. Next slide. They should move with respiration and again, should arise from the pleural line itself. Next slide. And here's an example in the setting of trauma, lots of B lines coming off that pleural line. Notice that they're moving with respiration. So I know there's not a pneumothorax here, but instead I know that with these B lines that there's contused lung. Next slide. Just another example here. Getting a little close on time, so yeah, come to the cases. So if we remember, we had a 7-year-old that was struck by mortar fire. She's hypotensive and tachycardic. Next slide. So do our ultrasound and we identify free fluid in the pelvis. And in a 7-year-old female, we wouldn't expect to see any free fluid in the pelvis. So we've got a positive FAST exam and she's hypotensive. So this needs to be addressed right away. We use the FAST exam quite a bit at the EFH. And especially when you're talking about penetrating trauma, small amounts of fluid are much more significant. Our other patient was a 31-year-old male. He was pale, diaphoretic. He had been struck by shrapnel from a grenade, and he was severely hypotensive and tachycardic. When we did the subcostal view, I think this is actually a parasternal view, but this patient ended up having a really large hemopericardium, ended up losing pulses and there's a bedside thoracotomy, and luckily we were working with some great surgeons, and they sutured up a left ventricular penetrating wound right there in the trauma bay, and took and despite coding in front of us, walked out of the EFH with a smile on his face. So definitely glory be to God for that. So next slide, just a real quick review of what we covered. I know I threw a lot at you, but the nice thing about this is this lecture is recorded, so if you want to re-watch it just to help reinforce the ideas, it's all in there for you. So remember, in the chest, we're trying to answer a few clinical questions. Is there a pneumothorax? Is there lung sliding? Moving all along the anterior chest, and I'll also look along the lateral chest for that lung sliding to see if there is a pneumothorax. Hemothorax, remember, going to move up from our left upper quadrant and right upper quadrant views, looking for a positive spine sign as a sign of fluid in the chest. Pericardial fluid, again, subcostal view, probe marker to the patient's right. We're going to drag the probe just a touch to the patient's right to scan through the liver. I'm going to lay that probe nice and flat, aiming towards the patient's left shoulder, and look for that stripe of fluid between the liver and the right ventricle for pericardial fluid. Ultrasound is better than chest x-ray for both pneumothorax and hemothorax, and it's definitely way better for hemopericardium. In the abdomen, we're looking for free fluid. Right upper quadrant, we're looking Morrison's pouch, tip of the liver, left upper quadrant, above the spleen and at the tip of the spleen. And then we want to do a sagittal view of the pelvis, looking in the pouch of Douglas in females and in that rectovesicular space in males. Remember, as the blood pressure gets a little lower, this test gets better. And also as ultrasound machines get better, this test also gets better. And it's always a good idea to repeat this, especially if they're not getting any sort of follow-up imaging. But a repeat abdominal ultrasound can be really helpful to pick up those really subtle, small injuries. So that's all I've got for you today. Thanks for having me.
Okay. Well, thank you so much, Dr. Rupp. Great presentation. I've heard you give this lecture several times, and I always learn something more. So thank you so much. To our listening audience, if you have any questions for us today, please utilize your chat box to the right. So far, Jordan, I don't see any questions coming in, but just a couple comments from myself. I remember I was there at the field hospital in Iraq there when that gentleman came in with the hemopericardium, and he definitely came to the right place at the right time. But I've never seen anything like that in all my life. I mean, the gentleman, he took a shot to the left ventricle and had, the EFAST. You all conducted the EFAST exam and diagnosed him with the hemopericardium. He got the emergent thoracotomy, and we had the right surgeons there to take on the case, and the gentleman walked out in a number of days. There's
pretty incredible.
Unbelievable. So there's a great example of the clinical utility of the EFAST exam and how it can save lives. And I think as you and I discussed prior to this presentation, I think that clinical care, that ultrasound is definitely changing clinical care. As you already said, it's superior to chest x-ray for pneumothorax, and certainly it's a lot more efficient and fast, like relative to CT scanned or other diagnostics for blood in the abdomen and pelvis. So and the technology is developing tremendously with much smaller and better ultrasounds. We talked about the butterfly, and there's going to be, I'm sure, a lot of other models coming out in the next few years where a lot of clinicians will just have them on their they're in their pocket, and you can just utilize it with like an iPhone. So pretty incredible technology.
Exciting times.
Very much. So we have a question posed by my friend Dr. Bruce Steffies. He says, Dr. Rupp, what are the rules of thumb for the significance of small hemothoraces and pneumothoraces that are not clinically apparent?
So typically for a pneumothorax, the general rule of thumb is if it's 15% in volume or less, then it can be watched. If it's a penetrating pneumothorax or from penetrating trauma, and then for hemothorax, typically 250 mLs is the cutoff. There is some early literature that's helping to describe techniques on how to quantify the size of a pneumothorax with ultrasound. That would be a whole separate lecture to try to go through that, but there are ways to do that. The one thing I would just be cautious is, with a chest X-ray, sometimes it takes 500 mLs to be able to see a hemothorax with chest X-ray, and then you can have moderate-sized pneumothoraces that are occult to chest X-ray, meaning chest X-ray doesn't pick them up and they're still decent size. So there can be some difficulties quantifying the size of a pneumothorax on chest X-ray. So I would look into, read up on the articles trying to quantify the size of the pneumothorax. But certainly if you're going to be able to closely watch and you feel like it's small, the pneumothorax can accumulate a little, or can resolve a little quicker if you have them on high flow oxygen. And if you can watch them close, you might be able to just watch and let the pneumothorax resolve spontaneously.
Very good. Thank you, Dr. Rupp. Any other questions? Don't see any at this time. Again, you did such an excellent job. There's limited questions here, but while we're waiting, just want to remind everyone that CME credit is available for this session. As always, the form and the instructions will be in the email, which we will be sending as a follow-up email with the link included in this recording. And just always remember, if you're not on our email list, you can join the forum at health.samaritans.org and be the first to know of our upcoming events. One that I want to just highlight is our annual medical conference, Prescription for Renewal, which this year will be taking place in Orlando, Florida, September 19th through the 22nd. Great speakers, Dr. Kent Brantley, Mike Huckabee, Nikki Haley, and many others. Also, just an incredible opportunity to learn more about opportunities and network in the medical sector at Samaritans First. So really encourage you to join us there. Next month, our webinar will be on Wednesday, June the 12th. It will be Dr. Greg Sund, who's a career medical missionary at Kabuye Hospital in Burundi. He serves as an anesthesiologist there, and he will be speaking about radiology in the developing world. So please do join us with that. Jordan, don't see any other questions. So again, thank you so much for a phenomenal presentation, and we appreciate you and the work you're doing at Vanderbilt.
All right, thanks so much for having me.
All right, thank you, and thank you to our listening audience. Please join us next month. Take care and God bless.